So what if I told you the true global cost of a single disease isn't measured in, like, hospital bills or pharmacy receipts,
Right.
but in roughly $78 trillion of invisible, unpaid labor?
It's a staggering number.
It really is. Today, we are basically tearing up the traditional map of metabolic health. Welcome to this deep dive. We're looking at a condition that affects hundreds of millions of you, directly or indirectly.
Absolutely.
It shatters standard medical boundaries. It's quietly reshaping the global economy. And, I mean, it is currently undergoing a scientific revolution that borders on science fiction.
Yeah, we are talking about the escalating global crisis of diabetes. It's a condition that has fundamentally altered the trajectory of human health.
Right.
And understanding it requires looking far beyond, just a simple blood sugar reading.
Exactly. And to bring you this deep dive, we're pulling from a pretty massive stack of research today.
A very heavy stack.
Yeah. We've got global health fact sheets from the World Health Organization, the latest statistical updates from the American Heart Association.
Oh, and that comprehensive macroeconomic modeling published in Nature Medicine.
Yes, that one is wild. Plus, we have some cutting-edge clinical research on AI integration and gene-edited therapies.
So our mission today is really to just cut through all that heavy medical jargon. We want to help you understand the mechanics of this, not just why this metabolic crisis is reshaping communities, but exactly how a new wave of technological and pharmacological breakthroughs might fundamentally rewrite the future of the disease itself.
Let's start with the true staggering scale of the threat, because it really puts the necessity of these sci-fi breakthroughs into perspective.
Yeah, you have to understand the scale first.
Right. So right now, there are more than 800 million adults living with diabetes globally. That is a massive jump from just 537 million back in 2021.
It's a huge leap.
And the trajectory is incredibly steep. I mean, by 2050, projections point to 853 million people.
And when a disease reaches that kind of scale, the economic impact just becomes difficult to comprehend.
Yeah.
Standard economic estimates, they usually focus on direct medical costs, right? So hospital visits, insulin production, dialysis.
The stuff you can easily track on a spreadsheet.
Exactly. And those direct costs are projected to hit about $1.05 trillion by 2045.
Which is a massive number on its own.
Oh, yeah.
But the macroeconomic modeling we looked at today says that $1 trillion figure is severely undercounting the real impact.
It drastically undercounts it. I mean, traditional estimates completely miss what economists call the shadow economy of informal caregiving.
The shadow economy.
Right. Because we have to look at survival rates. In many regions, the prevalence of diabetes exceeds its mortality rate by a factor of 30 to 50.
Meaning people aren't dying from the initial onset. They're surviving for decades while managing these severe chronic complications.
Exactly. Decades of needing daily assistance with mobility or administering medication, dietary management, basic living tasks. And that care doesn't come from a hospital. It comes from unpaid family members who, often have to leave the workforce entirely or severely reduce their working hours.
Right. Someone has to be there to do the work.
Yes. So the new modeling quantifies this opportunity cost, the lost wages, the stalled careers, the missing tax revenue. When you factor in the value of this lost labor and unpaid caregiving, the global economic burden from 2020 to 2050 surges to an estimated $78.8 trillion.
Over $78 trillion.
Yeah.
I mean, if we look at direct medical costs, like the physical damage of a natural disaster, like broken windows or flooded houses,
Sure.
This informal caregiving is like the permanent closure of a town's main factory. It's this underlying economic sinkhole that just drains productivity year after year.
That's a great way to put it. And that shadow cost represents roughly 1.7% of the annual global GDP.
That's incredible.
It diverts immense resources away from education, infrastructure, capital accumulation. It just functions as a slow-moving macroeconomic tsunami.
And what's crazy is that this economic sinkhole isn't opening up where we typically expect it. Based on our sources, the geographic and demographic map of this disease is completely flipping.
Oh, totally. If you look at global hotspots right now, the Middle East and North Africa region, so the MENA region, has the highest age standardized prevalence at 19.9%.
Wow.
But the region we really need to watch closely over the next couple of decades is Africa.
Which, currently has the lowest rate globally, right? Around 5%.
Currently, yes. But it is projected to explode by 143% by the 2040s.
143%.
Yeah, it's driven by a physiological phenomenon epidemiologists call the double burden of malnutrition.
Okay, so how does that actually work mechanically? How do you have undernutrition and skyrocketing diabetes at the exact same time?
Well, it comes down to metabolic adaptation. You have populations that historically face severe caloric restriction, real undernutrition. Biologically, their bodies adapted to aggressively store every available calorie just to survive. But suddenly, as these regions urbanize, they are just flooded with cheap, ultra-processed, highly caloric foods.
Oh, I see.
So you end up with childhood stunting and undernutrition coexisting with rapidly rising obesity, sometimes within the exact same household.
That is wild.
The body's ancient survival mechanism is just completely overwhelmed by the modern food environment, which creates this massive metabolic whiplash.
And the data shows that 95% of the global increase by 2050 will happen in low and middle income countries.
Yes.
Total volume is highest in countries with massive populations like China, India, and the US. But the highest actual rates, like the density of the disease, are in places like Fiji, Kiribati, and the Marshall Islands.
Right. It is fundamentally a crisis of rapid urbanization outpacing the development of public health infrastructure.
Which actually brings up a fascinating paradox in the US data. We looked at a CDC report from 2021 on the urban-rural divide. It showed diabetes prevalence was 14.3% in rural areas compared to 11.2% in urban areas.
Right.
But hold on, if cities are the epicenters of fast food, 247 food delivery, and sedentary desk jobs, why are rural areas seeing significantly higher risks?
Well, when researchers dug into that data across 19 U.S. states where rural risk was significantly higher, they ran adjustments. They controlled for age, sex, race, income, education, and baseline obesity levels.
Okay.
And once they adjusted for all those factors, the rural disparity just vanished in almost every single state.
Except for North Carolina and Oregon, right?
Except those two. But basically, the geography itself isn't the root cause.
So the rural penalty is essentially a mirage.
Pretty much. It's not about the physical environment of living in the country versus the city. It's entirely about sociodemographics.
Oh, I see.
Rural populations in the U.S. tend to skew older, they experience higher rates of poverty, have way less access to preventive primary care, and exhibit higher baseline rates of high body mass index.
So the zip code is just a proxy for systemic health disparities and poverty.
Precisely.
Because once someone falls into that demographic risk pool, this disease doesn't just stay neatly in its lane.
No, not at all.
To understand why diabetes drives such immense caregiving costs across all these different demographics, we really have to look at what's actually happening inside the body. It acts as the first domino in this devastating physiological chain reaction.
Right. And the American Heart Association recently defined a new clinical term for this: cardiovascular kidney metabolic syndrome, or CKM.
CKM?
Yeah. They created this classification to formally recognize the deep, inseparable mechanical connections between heart disease, kidney disease, diabetes, and obesity.
I picture the body's vascular system kind of like a city's plumbing.
That's a good analogy.
If you pump highly corrosive water through a city's pipes, which is functionally what blood with chronically high sugar is,
Yes, exactly.
it doesn't just break one single sink. Over a span of years, it eats away the heavy pipes in the central pumping station, which is the heart, and it completely destroys the delicate filtration plant, which is the kidneys.
The physiology mirrors that perfectly. High blood sugar causes molecules to literally attach to proteins in the blood vessels, causing endothelial damage. It stiffens the vessels.
Wow.
And the data from our sources really illustrates the fallout. Type 2 diabetes deaths caused specifically by high BMI surged 203.9% since 1990.
Over 200%.
Yeah. And when that vascular plumbing fails, the heart takes the hardest hit. Heart failure is the most fatal complication here. A patient with type 2 diabetes who develops heart failure has a 3 times higher 5-year risk of death.
And the kidney filters are failing in parallel to all this. Our sources note that 600 to 74 million people globally have chronic kidney disease, or CKD, which is permanent and irreversible.
Right. And alongside that, you have acute kidney injury, or AKI.
And how is that different?
Well, this happens suddenly, often from a severe infection or dramatic dehydration. And while an AKI event can be reversed with immediate clinical treatment, the physical trauma to the kidney tissue permanently raises the patient's risk of developing irreversible CKD down the line.
So the damage is cumulative.
Highly cumulative. Today, kidney dysfunction accounts for nearly 12% of all global cardiovascular deaths.
And this plumbing damage is starting earlier and earlier. I mean, the biological clock for this disease used to be something we associated primarily with the elderly.
Right.
But now is starting before people are even born, we are seeing a massive shift toward intergenerational risk.
It's a huge shift. While 1 in 4 adults with diabetes is over 65, the fastest growing and most aggressive trend is youth-onset type 2 diabetes.
Wow.
And the biological roots of this often trace directly back to pregnancy. Gestational diabetes, which is hyperglycemia or high blood sugar occurring during pregnancy, now affects 1 in 6 pregnancies globally.
1 in 6. And the ripple effects of that are severe. For the mother, having gestational diabetes means an 8 to 10 times higher risk of developing type 2 diabetes later in life.
Right.
But for the child, we have to examine the mechanics of what they call metabolic programming.
Yeah, this is key. When a fetus develops in an environment of maternal hyperglycemia, it is constantly exposed to excessive amounts of sugar.
Okay.
To handle that massive sugar load, the fetus's own pancreas goes into overdrive, producing massive amounts of insulin. This is called fetal hyperinsulinemia.
Oh, wow.
But here's the thing. Insulin doesn't just process sugar, it also acts as a very potent growth hormone. It literally forces the developing fetus to create and expand fat storage cells.
So they're essentially born pre-wired for metabolic dysfunction.
Exactly.
I mean, we constantly hear type 2 diabetes framed purely as a failure of willpower. Like, it's a bad diet, it's a lack of exercise, it's poor personal discipline.
All the time.
But if an infant's fat cells are biologically programmed in the womb to relentlessly hoard energy before they even take their first breath, doesn't that completely rewrite the narrative of personal responsibility?
Absolutely. It exposes just how biologically flawed the stigma around this disease really is.
Yeah.
You literally cannot out-willpower metabolic programming that was locked into your cellular structure during fetal development. Acknowledging that biological reality over the societal stigma is really the only way we can approach effective systemic treatment.
So we have a disease that rewires fetal biology, systematically destroys vascular plumbing, and drains $78 trillion from the global economy. How is modern medicine actually fighting back? Because, the picture of intergenerational CKM syndrome looks incredibly grim.
It does look grim.
But science is launching a major counterattack. We're entering this wild era of multi-hormone drugs, artificial intelligence, and gene editing.
Yeah, the pharmaceutical advancements alone represent a complete paradigm shift.
Oh, yeah.
For a long time, medications targeted a single biological pathway to try and lower blood sugar. Then we saw the development of dual agonists, like tirzepatide, which target both the GLP-1 and GIP hormone receptors.
But the new frontier highlighted in the research is triple agonists, specifically drugs like retatrutide.
Yes, retatrutide targets 3 distinct receptors simultaneously: GLP-1, GIP, and glucagon.
So if the older single-pathway drugs were like installing a basic smart thermostat to just lower the temperature in one room, retatrutide is like installing a fully integrated smart home system.
I love that.
It simultaneously cranks the air conditioning, opens all the windows, and actively shuts down the furnace in the basement.
The biological mechanism works precisely like that coordinated system. So the GLP-1 receptor slows gastric emptying and signals fullness to the brain. That's your air conditioning.
Okay.
The GIP receptor enhances insulin secretion to handle sugars efficiently opening the windows. But the addition of glucagon is what shuts off the furnace.
Because it actually increases energy expenditure.
Exactly. It actively increases the body's resting energy expenditure. It forces the body to stop storing energy and start burning existing fat.
That is incredible.
In clinical trials, retatrutide caused an average 16.8% body weight reduction. We are seeing metabolic resets that historically required highly invasive bariatric surgery.
And the breakthroughs aren't just in type 2. Let's look at type 1 diabetes, which is an escalating autoimmune condition where the body actively hunts down and destroys its own insulin-producing beta cells in the pancreas.
Right. Very different mechanism.
Yeah. And in the past, if a patient received a transplant of new islet cells, they had to take heavy immunosuppressant drugs for the rest of their life just so their body wouldn't reject a cure.
Which leaves the patient incredibly vulnerable, to a host of other infections, viruses, and diseases because their immune system is artificially suppressed.
But now companies like Vertex are using CRISPR gene editing to create what they call hypoimmune or stealth islet cells.
This is truly considered the holy grail of type 1 diabetes research.
The holy grail.
Yeah. The immune system identifies foreign bodies by scanning for specific protein markers on the surface of cells. Think of them as biological ID badges.
Okay, that makes sense.
Using CRISPR, scientists are editing the genetics of lab-grown beta cells to completely remove those ID badges.
So when they transplant it into the patient, the immune system's T cells just walk right past them.
Exactly. The stealth cells begin producing insulin naturally, regulating blood sugar perfectly, and they hide completely from the patient's immune system. It eliminates the need for lifelong immunosuppression.
It's unbelievable. And it's not just the drugs and the gene edits, It's how we are detecting the CPM damage in the first place.
Right.
Like diabetic retinopathy is a major cause of blindness. Duke Eye Center is currently launching the first large-scale AI point-of-care screening right inside endocrinology clinics.
Yes.
It scans the patient's eyes and gives result in 30 seconds. But wait, are we seriously trusting a 30-second computer algorithm to catch creeping blindness over an actual retinal specialist?
It's an understandable concern, for sure, but it kind of frames the clinical problem incorrectly.
Oh, how so?
Well, the AI isn't there to beat a retina specialist in a head-to-head diagnostic match. It's about scale and immediate triage. Millions of patients skip their annual eye exams because scheduling a separate appointment with a specialist is time-consuming, expensive, and often requires taking more time off work.
Oh, that makes total sense.
By putting the AI directly in the clinic they are already visiting for their routine diabetes checkup, you catch the disease at its earliest stages.
Right.
The AI flags the high-risk patients on the spot and then routes those specific patients to the human specialist for treatment.
And the research highlights a really critical detail about how this AI operates, because historically, medical algorithms have struggled with severe racial bias, right? Since they were trained predominantly on lighter skin tones.
Exactly. Huge issue.
But to ensure this retinal AI is fair, researchers aren't using standard demographic labels to train the system. They're using a metric called a retinal pigment score, or RPS.
Right.
Oh.
Demographic labels like race or ethnicity are social constructs. They are highly imprecise descriptors of human biological variation.
Very true.
By utilizing the retinal pigment score, the AI measures the exact biological concentration of melanin in the back of the eye on a continuous scale.
Oh, okay.
It decouples the technology from flawed social labels and ensures the algorithm performs equitably for everyone, identifying the damage accurately regardless of a patient's skin tone.
These sci-fi solutions are incredible. I mean, they really are.
They're amazing.
But there is a massive reality check we have to address. The triple agonists, the stealth cells, the unbiased AI, none of it matters if the people living in those expanding geographic hotspots in Africa or the rural U.S. or the Man-A region can't actually get access to them.
You're completely right. This is what public health experts call the implementation gap.
The implementation gap.
Yeah. And to try and bridge this, the World Health Organization launched the Global Diabetes Compact. They established 5 core targets for the year 2030.
Let's run through those.
So it's 80% of people diagnosed, 80% achieving good glycemic control, 80% achieving good blood pressure control, 60% of those over 40 receiving statins for heart protection, and 100% of type 1 patients having access to affordable insulin.
I mean, those are incredibly ambitious targets given the reality on the ground.
Extremely ambitious.
The data from Pakistan shows that 1 in 3 adults has diabetes, yet their primary healthcare system remains heavily fragmented. In India, only 7 to 11% of patients are regularly tested for complications like kidney or lipid issues.
And across the board, particularly in low and middle-income countries, high out-of-pocket costs remain the absolute primary barrier to treatment compliance.
Oh, for sure.
You can engineer the most advanced triple agonist in the world, but if a patient has to choose between purchasing that medication and feeding their family, the scientific breakthrough is utterly useless.
It's like engineering a state-of-the-art high-speed bullet train that can outrun the disease, but completely neglecting to lay down any tracks in the communities that actually need it most.
That's exactly what it is.
We have the technology to stop the CPM domino effect, but the delivery infrastructure is broken.
Which is why those WHO targets focus heavily on the basics. Health equity, integration into local primary care, and drastically lowering the cost of basic blood diagnostics are just as critical as CRISPR gene editing.
Absolutely.
The science is winning the battle in the laboratory, but now health policy and economic structure have to win the battle in the streets.
So let's bring this all together. We started by looking at the invisible $78 trillion macroeconomic sinkhole of informal caregiving and the way this disease acts as the first domino, just destroying the heart and kidneys through vascular damage.
Yeah.
We've seen how the risk is passed down intergenerationally, metabolically programming infants in the womb. But we've also seen the incredible counterattack. Drugs that mimic three hormones at once to burn fat, AI that predicts blindness in 30 seconds without demographic bias, and CRISPR-edited stem cells that hide from the immune system.
And for you listening, this goes far beyond an abstract medical discussion. This is about the future viability of your local healthcare system. It's about the global economy you participate in every day. And given the sheer prevalence of metabolic syndrome, it is highly likely it will dictate how you or someone in your family manages personal health in the coming decades. The old boundary lines of medicine have just been completely erased.
Which leaves us with one final thought to mull over. We started by talking about how we traditionally like to put diseases in neat little boxes, contained, managed, treated over a lifetime.
Yeah.
But with AI learning to instantly predict cellular damage and gene editing, figuring out how to hide lab-grown beta cells from our own immune system's hitmen, are we moving towards a future where chronic diseases like diabetes aren't managed by daily choices anymore?
It's a huge shift.
Are we approaching a reality where a disease is simply deleted from our biology, like patching a software bug? And if we do reach that incredible sci-fi reality, who gets the update first?
That will undoubtedly be the defining question of the next era of medicine.
Thanks for joining us on this deep dive. We'll catch you next time.